Well, good afternoon, and welcome to the Brain Injury Alliance of Iowa's noon webinar on REAP, the benefits of good concussion management. We have with us today Dr. Karen McAvoy, and we'll be starting in just about 1 minute. All right, if we can get into presentation mode, we'll be good to go. Right now we're in screen mode. I'll do some introductions while we get that going. Again, my name is Jeffrey Lauer. I serve as the Executive Director of the Brain Injury Alliance of Iowa. Today we welcome Dr. Karen McAvoy, who serves as a who's credentialed, as a licensed psychologist and also a school psychologist. She was a school psychologist at the high school that was attended by Jake Snackenberg in Colorado. That was the Cherry Creek School District, when he passed away as a student from second impact syndrome in 2004. Karen, in collaboration with members of the school district, then developed the community-based multidisciplinary team approach to concussion management called REAP, which stands for Reduce and Remove, Educate, Adjust and Accommodate, and PACE. In 2011, the Colorado concussion bill that required concussion management in school districts was named the Jake Snackenberg Youth Concussion Act. And Dr. McAvoy opened, and she directs the Center for Concussion at the Rocky Mountain Hospital for Children. She has a BS in psychology from the University of Washington in Seattle and a doctorate in clinical psychology from the University of Denver. Karen, are you on the phone?
I am. Can you hear me okay?
I can hear you. Welcome to Iowa. We're just looking at your screen and checking to see whether or not as we'd hoped. Right now I see a screen called built-in display, and I don't think we are able to see your slides quite yet.
Okay, we are working on getting those to you.
Yep, no worries. I understand. So that's, in the world of webinars, we have sometimes a couple of glitches, so we'll let you do that here for a second, and we will continue in a couple of different areas. I should talk about the Iowa Concussion Consortium. The Iowa Concussion Consortium was formed late last year, and it's a partnership of a range of organizations, including the Brain Injury Alliance of Iowa, the Iowa Advisory Council on Brain Injury, the Department of Public Health, and the Department of Education have both endorsed the activities of the Concussion Consortium. Say that 3 times fast. As well as endorsing the REAP manual as the protocol for Iowa schools. In addition, we have the Iowa Athletic Trainers Association, the Iowa High School Athletic Association, Iowa Girls High School Athletic Union. Those latter two, the High School Athletic Association and Girls High School Athletic Union, are embedded in Iowa law, the Iowa Youth Sports and Concussion Law, which was passed in 2011. As organizations that are required by law in Iowa to identify and support specific concussion protocols. And the Centers for Disease Control have concussion protocols that are acceptable, but the Iowa Athletic Association and Girls Athletic Union have also endorsed REAP as a more multidisciplinary approach. We also have on deck St. Luke's Hospital, Unity Point, Neurorestorative, the Centers for Disability and Development at the University of Iowa, and a range of others that you can find on our website, which is at biaia.org/ICC, which stands for Iowa Concussion Consortium. Do you think that you need a little support there for the screen, Karen?
We're trying to manage here real quick.
No worries. You're good. I just want to know if you want to change the presenter over to me, and I can flip the screen from my end, or however you do it. We're here to support you, however you need to do it. But they say that Murphy's Law, if it can go wrong, it will go wrong for a second. But Karen, why don't you take a minute while we get the screen set up, and just go ahead and introduce this concept and how we came to be here.
I'll start talking through this. So first of all, I'm very happy to be here for Iowa today. And the last night and tomorrow, hitting a number of different areas, different groups, and talking through REAP. And I'm very excited for Iowa to have their own version of REAP. So what I will do, and many of you have already maybe been part of a webinar before in the past where I have talked about REAP, what I'm going to do is focus a little bit today on the academic aspects of REAP, the multidisciplinary team on the school academic team side. So just a little bit of history. REAP really came out of the incident that we had in Colorado in 2004 when Jake Snakenberg passed away from second impact syndrome. And for all students and for all states that were dealing with this with students, that led to the legislation of return to play laws across the United States. So in 2009, Washington State started with return to play legislation, and it covered all 50 states by 2014. And all of the return to play legislation has covered things like education to certain stakeholders, removal from play for suspicion of concussion, and then return to play by various medical personnel. And so what we tried to do in 2009 when I wrote REAP was to pull together the various teams that needed to surround a student and make sure that they were safe. And the Iowa version now has now customized those same 4 teams for your own community. And while many of our return to play legislation laws have come out of the serious incidents of permanent brain damage or death, when you actually look at the overall numbers of recovery for children and adolescents with concussion, the odds are really very good. Much of the research in the past has shown that about 80 to 90% of students will recover from a concussion in about 3 to 4 weeks. A new study that came out in 2016 by Zemek et al. Showed that at about 28 days, which is 4 weeks, 70% of kids were recovered from a concussion. So that's leaving about 30% of kids that are going into 1 month beyond in terms of recovery. So when you look at those odds, they're really very good. And that means that we as healthcare providers, we as athletic trainers, coaches, and educators can really impact on the front end that recovery. We have 3 to 4 weeks in there where we really can be supporting very good management and really promoting recovery. So if you go into the Colorado version of REAP and now the Iowa version of REAP, we have outlined that there are 4 teams necessary to support our students. One is the family team, and one is the medical team, and then the school team has really 2 teams. It's the school physical team and the school academic team. And those 2 are very intricately connected, where if you have at your school an athletic trainer or coaches who are really kind of covering the school physical team, you also need to make sure that you have academic educators. Are these slides up and running now?
They are not, but
okay.
You align with what slide you're at, and Jeff's going to click, and we're going to have you click, tell him when to click.
Okay. I'll just keep on going until you tell me otherwise.
Yep.
All right. So what we have done in Colorado and what Iowa is doing this weekend is to get the general information about REAP out there and then take each one of those teams and do a little extra training in each one of the areas. So
Karen, let me interrupt you and just say the slides are up, and I'm going to advance them for you. You can see the cover slide, right?
The one that has it's
got
lack of
kids. I can, whichever one I can do. It says it's not a lack of information, it's a difficulty of implementation. Would you like to go forward or backwards from there?
Can you go all the way up to the seamless system of communication and collaboration slide?
Yes. How many forward is that, do you think?
That's
I'm there. I just found it. We're there. You just tell me when you're ready to advance, and I'll advance the slides.
hey, great, perfect. Okay.
Yeah, we're good. Thank you so much. Sorry.
No problem. So those are the 4 teams right there, and you can see that the school team has the physical team and the academic team, light blue and dark blue. So go ahead and advance the slide. So then REAP really just becomes your roadmap forward, a common language to start on the important things that we all need to work together on, but every one of those groups then needs a little extra specific training in certain areas. So like I said, today we're going to focus a little bit more on the academic side. For those of you that are educators and coaches, athletic trainers who are working closely with schools, or clinics, hospitals who are working closely with schools. So the next slide is just a definition of concussion from the 2012 consensus statement. And I'm sure you have all seen that before. Basically, it's a very complex process of what happens cellularly with a concussion. If you go to the next slide, Jeff, it breaks it down into the various parts that are looked at when we're making the definition of a concussion. And that a concussion can be a direct blow to the head, but it does not have to be a direct blow to the head. And it usually results in the rapid onset of short-lived impairment neurologically that's shown in signs and symptoms. And so if there are any coaches or school nurses on the line that are wondering what those signs and symptoms are, Jeff, if you go to the next slide, signs are going to be the actual behavioral manifestation that you would see in a student. So if there was a hit to the head and then the student appeared dazed, or was asking the same question over and over, or was clumsy, those are going to be things that even if the student is saying, I feel fine, you're going to actually see signs. The next slide, though, are symptoms of a concussion. And those are showing the different manifestations that the student might report. So I have a headache, I feel dizzy, I feel nauseous, those kinds of things. And so if you're a coach or athletic trainer and you're assessing this on the sideline, you're really looking for both signs and symptoms. If we go back to our definition, the next slide, the next thing we need to really be aware of with a concussion is that because it is a cellular injury, it's not a structural injury, it will likely not show up on a CAT scan or an MRI. And just because you have a completely normal CAT scan or MRI, if a medical setting chooses to do that, it doesn't mean then you haven't had a concussion. If you have signs and symptoms, you've had a concussion. And the reason why it's important to understand the cellular mechanism behind this is because it becomes a very important part in management. So the next slide shows that really what a concussion is an energy crisis. It's basically a phenomenon where there is an imbalance of chemicals within the cell versus outside of the cell, and what that does is it renders the cell to be inefficient. And that's an important strategy to understand, or important definition to understand, because if you go to the next slide, Jeff, what is really helpful for our students, our teachers, our parents to recognize about a concussion is that it is not a bruise and it is not a bleed. The way that I describe this to the patients that I work with every day and to schools and parents when I'm doing trainings is that while the student is concussed, they are a lot like a car with a very small gas tank. And the reason why that is important is because they need to understand that just like a car with a small gas tank, you can get out of the garage. So you can go to school, you can do some things, but you're not a race car right now. You're not that efficient. And when you begin to run on empty, and that might happen sooner than it did when you didn't have the concussion, you will flare symptoms, and the symptoms are simply telling you that you're beginning to run on empty. If you cut it back slightly, if you take a little break, if you refuel, you'll be able to then start moving forward again. And the importance of understanding this is that it begins to move us into this theoretical understanding that a concussion is something that will take a number of weeks to heal, and during that time, we want to find the sweet spot of how much activity we can do cognitively and with home stimulation, and maybe even physically, without provoking symptoms or delaying recovery. And so you can see from my little analogy there with the gas tank that what's important for our students and parents to understand is that symptoms will wax and wane, and recovery will continue to happen during 2 to 3 to 4 weeks as long as we are not overworking that brain. And so for our students, we want them to be at school with the school supporting them. If they will learn a little, rest a little, take frequent breaks, take some refills, and basically drive the car a little bit differently, drive it, fill it. So that becomes an important management strategy that I'll talk about when we are talking about getting these students back to school. If you go to the next slide, Jeff, it goes back to the definition of a concussion, and we're basically just trying to focus on the fact that it's important for our kids and our teachers and our parents to understand that this recovery generally takes 2 to 3 to 4 weeks. Unlike what you see with many of the adult concussions, which may take 3 to 4 days, 7 to 10 days, it could be longer for children and adolescents. And it's helpful as a team to let our children understand and let our young athletes understand that this may just take time for the brain to heal. And during that time, there are many things they can do to help the recovery, and a couple of things they can do to make this go longer. So we really want to engage them in their own rehab. So having said all of that, we know that this has been a condition that we have followed closely with contact sports. And you can see in the next slide that there are certain sports that are at higher risk than others. Football, of course, is always the highest. But keeping in mind that the Centers for Disease Control have been tracking concussions or mild traumatic brain injuries for many years, and there are many students or kids who have concussion from recreational activities or from just falls or motor vehicle accidents or assaults, and they're not sports related at all. So the next slide just indicates that we need to make sure that we're taking care of all of our kids. Many of our kids who have a concussion don't play sports at all, and we want to make sure that we have a system for recovery, return to learn, and return to play for all of our kids, no matter how they got their concussion. And that's really what REAP focuses on. So the next slide shows that the first step in REAP, at the very beginning of a concussion, shows that all teams are involved in removal and reduction of stimulation, right from the very beginning. And the next slide is actually the remove reduce page, and you can see that every team member has an important part in removing the student from physical activity and reducing some of the cognitive and or home stimulation demands. The next slide shows that
breakdown. Let me pause here for a second, Dr. McAvoy, and just two things I need to do of housekeeping-wise. First of all, for folks, this manual is available at the Brain Injury Alliance of Iowa's website. It's the one it's customized for Iowa. And so the pictures might be a little different because we've Iowanized it, but this whole concept on the right-hand side of the screen regarding the steps and the teams is the same. We've got some stories, instead of about Jake Snackenberg, we have stories about Iowans. The second thing is, on the right-hand side of your go-to webinar control panel, if you have questions for Dr. McAvoy or something's not making sense, please type in your question. And I'm happy to do air traffic control around questions. So I'll be taking track of questions as we go, and then at the end we'll have some time for questions and answers. I apologize for interrupting you.
No problem at all. Yeah, and we will try to have a little bit of time for those questions at the end, because I want to make sure that I'm really specifically getting to your needs. So
you bet.
Yes, good point about that. The pictures that you see in the slides are the Colorado version, but the content remains the same. When it's customized for different states, then it's your own state story or your own resources. So thank you for pointing that out. So in the remove and reduce slide, obviously the most important thing that we're all focusing on is removal from another potential head injury, and that's why we remove all of our students from any physical activity, from PE, from physical play at recess, from recreational sports, and from organized sports. And those are kind of the black and white decisions. It's just safer to remove them from that, although there's some good information now that's moving towards a little bit of physical activity under supervision of a physical therapist. Obviously, there's a training that should go to coaches about sideline evaluation, which is more than what we will do today in this training, which is a little bit more for educators. But what we're looking for in sideline evaluation would be those signs and symptoms, the mechanism of the injury, and just making sure that they are first and foremost safe and taken care of and taken to a hospital if need be, etc. So that would be a little bit more or different than this training. Once we remove them from physical activity, then we also want to make sure that we're reducing the stimulation at home and reducing the stimulation at school. And those are not black and white decisions. Those are shades of gray, where if you cut down the demands for a student on a Monday, they may actually be able to do some of that academic work by Thursday. So we want those to be very immediate, we want those to be very fluid, and we want the schools and the parents to feel comfortable in understanding and recognizing the symptoms to be able to move these students forward.
Question that just came in on that. I'm going to just interrupt because it's timely. Can those symptoms, the question is, can those symptoms be episodic? Can they be better on one day and then worse, or do they typically get better as time goes by?
So the answer to both of those is yes, to both. They do typically get better as time goes by, but it is very much because it's an energy crisis, there are some things that are more taxing to a child than others. So let's say a child is having a fairly good recovery, has a fairly good day, headaches are not debilitating, but they're just annoying, they're slightly coming and going, and then the student goes home, feels pretty good, and he gets on the video screen for 3 hours and overdoes it. The next day, he may feel very sick again because he has overtaxed that system. So you will see the symptoms go up and down based upon the energy level and how much they've used those cells. And so it's a little bit like a rehab model where it's 2 steps forward, 1 back. And we try to educate our parents and our students and our teachers that that should just be something for us to pay attention to, but not necessarily panic about. Because overall, recovery from a concussion is a slow, steady progress forward. So we don't tend to have real setbacks, but we do tend to have some symptoms that come and go. So we want you to be able to read those symptoms and just adjust slightly, pull back a little bit, and then start to move forward again. Okay. So going on with the physical activity, so the next slide basically, you will notice that the colors on the slides will align with the team that needs to be aware of this. So removal from physical activity is really something that the school physical team kind of thinks about. Sometimes that's the school nurse in some settings, and that's the removal from PE and physical play and recreational sports. And coaches and athletic trainers like to meet with their students during this, but they really can't play them in any of the sports. The next slide shows removal from physical activity with more of the medical component is just a recognition that there are some underlying issues that happen for some of our kids that tend to delay recovery. So some of our kids who have vestibular issues or ocular motor issues, so that's eye tracking issues and inner ear balance issues, the students where the concussion has impacted their autonomic nervous system, we call that dysautonomia, where they're feeling very faint and lightheaded and their heart rate is working very hard. Convergence insufficiency, where they're having depth perception problems. All of those could be things that could slow the recovery and make our students very symptomatic. And so it's really important, if you have a concussion specialist or a doctor who is finding those, that they are in communication with parents and schools just to let the schools know we have some ocular motor issues or vestibular issues, and the school is going to want to take that into account with their academic adjustments. It doesn't mean that they can't be at school, but it does mean that the school is going to want to understand what does that mean in terms of how best to support that student. The interventions for dysautonomia, the faintiness, is just an increase in water and salt and avoid caffeine. And sometimes the doctors will allow a little bit of early exertion. under the supervision of a physical therapist, so you might be hearing about that. So it's very promising, all of the work that's happening with vestibular therapy, but we're not really expecting that to be done at school or in a PE class. So that is still a therapeutic intervention. So the next slide shows then, as time goes on, how the management really then begins to move over to what the parent does and what the school does. So in the second and third week, really making sure that the student is physically safe, but also now beginning to move forward academically and socially. And the next slide shows that everybody's involved with this student, but we're not all involved all at the same time. So management really then falls on family and school academic team. The next slide shows that what the family's really working on is limiting that texting, TV, video games, and some of the socializing and extracurricular, but beginning to move them forward. And with the academic team, they may be home for a couple of days in the beginning, but we begin to get them back to school with a reduction in work, and we begin to move them forward into the third or the fourth week. The next slide shows really then how the REAP book helps for the team around the students to understand what the symptoms are telling us. It's really just important for students and parents and teachers to understand that the symptoms are kind of like that light on the dashboard that says, I'm beginning to run out of gas, and let's refuel a little bit, let's stop, let's take a quick little break, let's get a water break, and then we can start to move you forward again. So the Educate is about understanding and reading the symptoms. In your Iowa book, as in the Colorado book, the next slide shows that we want to make sure that we are all checking in with these kids, looking at symptom checklists over time and reading their symptoms so that we're knowing if we're getting recovery. And the next slide shows what the parents are really focusing on, which is the reduction in stimulation and video games and extracurricular. And then let's go into a little bit about what the school needs to be focusing on as these students return to school. So the next slide is about returning to school. And while it is true that we should not put a student with a concussion back to physical activity until they're symptom-free, that does not hold true for back to school. We know that these students will have some symptoms as they return to school, but we want their symptoms to simply be annoying and not debilitating. So the next slide just puts this in perspective a little bit for us as adults. If we had a concussion and we needed to be out of work, we would likely be out of work for a couple of days, and then we would ease ourselves back in again, hopefully with some support from a very understanding boss and some help from our coworkers, and we would take more breaks. Maybe we'd come in late, maybe we would leave early, we would not take on extra curricular activities at that time. And that's the same concept that we want for our parents to understand for our students returning back to school. We don't want them to be out of school for 3 to 4 weeks. They will have periods where they feel better into that second and third week, but they're not 100%. And so again, that management strategy of being able to pace themselves and to be able to let the symptoms, wax and wane and not get out of control through the day becomes important. There's a lot more of this information on the website, getschooled-on-concussions.com, which is the next slide. And if you want more information about this and one-pagers to help your teachers and your parents understand that, it goes into more detail there. The next slide shows really, though, what we're really trying to balance is the sweet spot of rest. We know that cognitive and physical rest is important, but we know by research that if we have kept the student out for too long or down in bed or too sequestered for too long, we don't get recovery. And we know that if we put them back to activity too quickly, we don't get recovery. So really, the next slide shows we're really looking at the Goldilock Model. We are looking for what is just right. Too little and too much is not right. Right in the middle, and being able to understand the symptoms, being able to have the right amount of physical exertion if it's done in physical therapy, back at school with a reasonable load, involved in some activities at home, with the parents understanding what may be flaring the symptoms, and having a reasonable and realistic management strategy. It's just not going to be reasonable to say to a student that they can never text, or they can never be on a computer, or they can never read for 2 to 3 to 4 weeks, because that is a difficult strategy to handle compliance-wise over a number of weeks. So it's really a rehab model that we're moving into with concussion. The research on concussion and going back to school, and the next slide shows that for the most part, we want our students to be back to school when their symptoms are tolerable, short-lived, and amenable to rest. And usually that is after they have been home for a couple of days and then maybe return to school 4 or 5 days or into the next week. A study that was done by Thomas et al. In 2015 showed that compared to students who were kept out of school for 5 days of strict rest versus kept out of school for 1 to 2 days and then returned gradually back to activity, those students who were out for 1 to 2 days and then resumed their activities but at a moderate pace were the ones who did better in terms of recovery. So the next slide is out of the Colorado REAP that shows some guidelines in terms of returning to school. If they are really struggling, then generally they're home for a couple of days, and then when they can focus for about 30 to 45 minutes, they start to return to school with support from the school. So let me go into what that support might look like. The next page is actually, or the next slide is actually a page out of REAP that shows the symptom wheel. So as you know, the symptoms are going to flare in 4 different domains, and therefore there might be different interventions that work for various symptoms. And this will give you an idea of a place to start on how to support your students. But the next slide is really an article that I wrote for the National Association of School Psychologists that tries to break down the academic adjustments more along the lines of where the areas of concern are, not so much by symptoms, but the biggest area of concern with a concussion cognitively is that mental fatigue. If this is an energy crisis and the cells are only providing enough energy that takes the student only to about midway in the morning before they start to run on empty, then obviously what's really impacting and flaring symptoms and making concentration difficulty and making fatigue come on is mental fatigue. It's a cellular issue. Second to that is processing speed. Slow processing speed will happen with the inefficiency of those cells. And the third thing that will then impact learning is the ability to take in new information, short-term memory, and to be able to remember that, convert that into new learning. So when we do trainings for our educators, we really focus on those 3 areas. If you go to the next slide, really the biggest area that I want educators to think about is mental fatigue. If you had a student who was mentally fatigued for any reason, not necessarily from concussion, but it could be from concussion. So you have a student who has mono, or you have a student who has periods of low blood sugar when we're trying to get their insulin well managed, or if you have a student who is switching from one seizure medication that was well managed to a different seizure medication, and we have 2 to 3 weeks in there where we are having periods that they are more tired than other times, those are the strategies that you would use for those students are the same that we would use for our kids with concussion. They're just running out of steam, and how would you adjust for that in your area, your content area? If you are a math teacher, then one of the things you might do is to have the student do every other problem. That helps with mental fatigue. If you are a social studies teacher, your intervention is going to be different. Maybe you're going to have them listen and learn, but not do the work output writing the essays. So what we really want educators to think about is not to necessarily wait for doctors to tell you exactly what to do in your class, but to think about what would work for mental fatigue in your class. And is this a morning class? Is this an afternoon class? How is this a strength for the student? Was it a weakness before? All of those things are things to consider. And then as educators, you will be able to more immediately and more effectively be able to support the student. You can see in this slide that the main strategy that you want to give is frequent rest breaks. We call this pacing, where we allow the student to have just a 5 or 10 minute eye or brain break every so often, every 30 minutes or so, where they close their eyes or put their head down for just 5 or 10 minutes right in the classroom, and then they refuel and then they get back to work. That will keep the symptoms at bay throughout the day and prevent them from spiking and then crashing and burning. If the doctor says they have ocular issues, ocular motor issues, if they have vestibular issues, you can see there that there are some specific things that can help with that. But basically, it's just very fatiguing to, not be able to see the board. Do we need to move closer? Do we need to pass when it's quieter in the halls? Those are all various things that could really help with fatigue. The next slide shows.
Well, I'm going to pause. There's a question about this slide, if I may.
Okay.
Forgive me. Amy Tom Starr has a question about, do you recommend a temporary 504 plan, or do you feel like an informal teacher response, an informal plan is sufficient?
Good question. And there's a little bit more on 504s towards the end of this, but I'm going to jump in and answer this question now. Different schools have their own feelings about 504s. If 80 to 90% of kids with a concussion will turn the corner on a concussion in 3 to 4 weeks, then for the most part, there doesn't seem to be a need to do a 504 on a typical concussion that is being well managed with immediate, flexible, fluid academic adjustments. So if your school district can provide a really soft place for these kids to land, and in 2 to 3 to 4 weeks, 80 to 90% of your kids will be well supported and turn the corner on a concussion and clear, then no, a 504 is probably not needed. 504s might be a very appropriate next step for that 10 to 20% that is now a month out, and academic adjustments are helpful but not enough, and we need a longer amount of time and or we need more interventions. Then a 504 might be your next step, and you basically take your academic adjustments and you switch them into a more formalized plan called accommodations. And in that case, it's probably more than we have time to go into in this webinar, but we do have some guidelines on getschooledonconcussions.com that tell you when to do a 504, how to do a 504, what a 504 is, and what a 504 is not. So there's a small percentage of students who legitimately are kind of the protracted recovery that may need a 504 a month or two out. But there are some schools who never do a 504 and they support their kids just fine, and there are some schools who do a 504 a little bit earlier and they feel they need that to support the students. So it really is a school by school decision, but overall I think you need to look at how wide and how supportive is your overall management of students for your typical concussions, and can you get 80 to 90% of them through this with just very flexible and fluid adjustments in the general education classroom with the teachers empowered to make those adjustments. You probably have your highest yield that way.
Thank you.
All right, so processing speed would be the second most common thing you would see with any kind of head injury and with concussion. And with that, obviously, if you're just moving at a slower pace, you're not going to get through the same amount of work. So therefore, reducing the number of problems and doing oral versus written, these are all ways that you can cut down on the work output, which helps with slow processing speed. We ask teachers to consider things like, could you remove the non-essential work? Could you reduce the semi-essential work? Many of our students, the biggest mistake that most of my teachers make is that they will not adjust the amount of work, but they will just pile it up on the side, and they will say, when you are better with this concussion, you can owe me all of this work as well as any new work we continue to do. And for 2 to 3 to 4 weeks, the amount of work that piles up on the side can be quite anxiety provoking for these kids. And so actually, if we can get teachers to actually consider removal or reduction of some work and just keep a reasonable amount of work going focusing a little bit on makeup work if it's important for mastery, but focusing more on current work if possible. That will help with anxiety. And then the last thing that a concussion will really impact is learning new material, and that is really what school is about. And so teachers and students have to kind of consider as they're working through this, what's the most important thing for them to learn over 2 to 3 to 4 weeks. Again, if you had a student that was just not 100% there, either because they had mono or because their medications were not quite where they needed to be, and you're working them through, an important unit, what would you focus on to help them keep up on the important information, but maybe not have so much work output to do? Of course, this becomes an issue when we get to finals, get to tests. What are tests about? They're an assessment of mastery. So has the student actually been present enough to have instruction to learn the material, and can they retain the material? Those are the issues about testing. And, if a student has missed a good deal of the instruction, it becomes an issue for testing. And those are things that teachers need to think about. Maybe don't give a test if they haven't been exposed to the material, but if it's material that they know and they're not impacted in that area at all, they can take that test if that's not taxing to the brain. So those are the things that we want our educators to think about as they are working with their students. The next slide shows really that mental fatigue, processing speed, and short-term memory really impact instruction, work output, tests, and ultimately grades. And so if you're focusing in your content area on how to help with mental fatigue and processing speed, you're going to be doing the best you can for these students. The next analogy is the tree analogy that we use with our teachers to try to help get teachers to understand that we're doing more than just waiting until we have the symptoms flaring in the classroom. If a concussion is an inefficiency of the cells, which is basically the root of the tree, and it manifests in symptoms, which is basically the leaves turning yellow and falling off, what we really want our educators to think about is to strengthen the trunk, strengthen the mental fatigue, or work on the mental fatigue in your classroom. And there are a million ways you can do that, and you do every day with kids with ADHD or other medical conditions. Work on the processing speed and work on the memory issues. And in that way, you will hopefully be helping so these students are continuing to learn, but continuing to heal, and we are not necessarily manifesting symptoms that are coming out in the leaves. So the next slide shows that really if you can front load your interventions over the first week and begin to taper them back in the second, third, and fourth week, that's probably the best way to do it. And there's no need to wait for medical clearance to do so. Medical clearance is only about physical return to play. What you do in the classroom is completely within the purview of what schools do, and you do it every day with other medical or psychological conditions. The next slide just shows that basically over 3 weeks, the ability to do more activities will increase as the symptoms will go down. And that's that slow, steady progress forward that we generally see with a concussion. And so the next slide is the adjust and accommodate page. As time goes on, keep moving these students forward academically as you see fit. Know that if you go a little bit too much and you give them a test and it flares a headache, it's okay, back it down the next day and try to start to move them forward again. And we tell our parents the same thing. Let them try a little bit more socializing. Let them watch a TV show or two. Let them go to a busy, loud restaurant and try that out for us. Test it out. Because we want to test out those cells in these 2 safe ways before we get back to the physical. But eventually, all kids want to get back to their sport and back to recess. So the next slide shows how you would go through the process of assessing when is it time for them to go back to physical activity. And in the Iowa book as well as the Colorado book, the guidelines are when they are symptom-free at home, when they are symptom-free at school, when their neurocognitive scores look where we think they should be if you're doing neurocognitive testing. If you have input from your athletic trainer, from your physical therapist, from a coach, you can definitely take those symptom reports into consideration, and when they're off all over-the-counter medications for symptoms of a concussion. And then you may turn the page, turn the slide, and you're at PACE, step 4, which is when to return them to play. So obviously, from an educator standpoint, you must be back to learning before you go back to play. Return to learn before return to play. Because if you are symptomatic and academically you are flaring symptoms with reading, or you're still not taking tests, or you're not attending school, that would show that those cells are still vulnerable, and it wouldn't be safe to start the graduated return to play steps, which are outlined there, which are just the international guidelines. The next slide shows 2 pieces of objective data that you have in your book there. One would be the symptom checklist that you can have your students do, and the other is the teacher feedback form, which you can get into the habit of having your students go around and collect teacher feedback so that your teachers have a way to give input about how they think the student is doing cognitively. Do we have full cognitive recovery? Are they back to their pre-concussion learning level before we start to put them back to play? So the next slide shows then that basically once you've done the management for the 2 to 3 weeks, you're collecting your data. Are we 100% symptom-free at home and school? And if so, then we might give the return to play steps over to the athletic trainer or to a parent to do, to slowly move these kids back through the physical exertion piece of it and get them back to their sport.
I have a question here from Bill Dickerson, who's saying that in his school, that's a much longer time out of play than typical. So I guess, is there variation that you've seen around the country in terms of how schools deploy this? Your recommendations, I'm interpreting here. It sounds to me like these might be more cautious recommendations for return to play than many districts have had in the past.
Well, and the beauty of REAP is that you don't have to do this by time. If you have a student who you determine has a concussion and they return to school within a couple of days, and the teachers put in the academic adjustments, and within a couple of days they are symptom-free physically, the teachers are showing they are cognitively recovered, you go through these same 4 steps at whatever pace the brain is telling you you can go through it. The majority of kids, though, the research is showing is it's a 2 to 3 week process, simply because there are just a number of kids who are out for a number of days. When they return to school, it takes them a couple weeks to ease back into their academics, and then they do the graduated return to play. But it is definitely true that there are some kids who are having a quicker recovery. It would be the same 4 steps. It's just a little bit more accelerated, and it's completely based upon the objective data that the students are giving you and their teachers. So that would be fine.
Okay. Thank you.
So this gets then to the slide that had been asked earlier about the acute versus protracted recovery. You can see that we've been talking really about a 1 to 4 week process for an acute concussion. And with this last question, of course, it could be as short as a week in some kids. It's not common, but it happens. And that's fine. If they are objectively hitting the mark, that's fine. But when you go into 4 weeks and beyond, you begin to get into more of a protracted recovery. There's something holding up the recovery, and it could be a number of different things. The next slide shows that there are concussion modifiers like headache before the concussion, attentional issues, learning issues, underlying depression or anxiety, number of past concussions. Those are the things that by research have been shown to maybe make for a longer recovery. And then, of course, if your medical doctors are finding that there are ocular, motor, or vestibular issues or convergence insufficiency, and these kids are needing physical therapy, then, of course, it's going to take a little bit longer. And when a student is recovering longer for medical or psychological reasons, we want to leave their academic adjustments in place as long as they need them. And that's when you begin to wonder, do I need to formalize this a little bit more, make it adjustment into an accommodation, make it a 504? And that whole process of moving kids through higher levels of intervention, the next slide shows you is not foreign to us as educators. That is the response to intervention model. That is the multi-tier system of support model. For all of our kids, we start in general education and we give general academic adjustments, no matter whether it's a learning issue or a behavioral issue, and 80 to 90% of our kids respond to that universal level. If not, and it's taking longer and there's something more complicating, then we go into tier 2, which would be the targeted interventions, and that might be when we start looking at possibly a 504 secondary to some issues from the concussion, and see if giving a little bit more time, more formalized interventions, and more prescriptive interventions might help. And then as a very last resort, do we go to tier 3, which is a permanent disability now, which is special education. And we rarely do that, but it has been known to happen. So if you want more on protracted recovery, that would actually be probably a whole nother webinar, and I'd be happy to come back and do that. We spend a lot of time on trying to get our schools comfortable with the typical recovery, that because we can impact 80 to 90% of our kids with just some good academic adjustments. But you know, for some schools, they're doing all of that and they want to know what to do for that 10 to 20%. So there's more information on the GetSchooledOnConcussions.com website, when to do a 504, how to do a 504, and of course, you know, return to learn before return to play is always part of our mantra. Question there of, is there ever a reason to write an IEP for a student with a concussion? The answer would be no. But is there ever a reason to write an IEP for a student that had a concussion that resulted in a brain injury that was significant, severe, and permanent, that resulted in needing to have specialized instruction, programming, placement, or modification of curriculum? In very rare occasions, yes. But that would be an IEP for a brain injury. And at that point, it's not really fair to be calling this a concussion. If a student has a serious outcome from that started as a concussion that's now resulting in permanent or severe interventions, that would be a brain injury. And yes, a team can move forward with an IEP, but that would be a pretty rare event, very small percentage of the time.
So there was a question here, and I think you've answered it. I just want to ask one variation on it. A concussion doesn't necessarily result in a disability from a brain injury, but a concussion is a brain injury, right?
Exactly. A concussion, then that's a very good question, because that's exactly what we're saying. A concussion actually is a brain injury, but we don't generally go around calling a concussion a brain injury, because for the most part, a concussion is, we hope, mild, short-term, transient, no long-term impact, and the research is showing that that pretty much is the case. So people in the public are much more comfortable calling this short-term issue a concussion, knowing that the idea is that a concussion will resolve, hopefully, without any long-term effects. But if you have a situation where a concussion, for whatever reason, is now leading to long-term, permanent, and very significant impact, then at that point, yes, it's probably much more descriptive to call that a brain injury and not a concussion. And do we support kids with brain injuries in schools? Yes, and we can. But that would be a brain injury, not really fair to call that a concussion. But
thank you.
You're right, on the same continuum.
Got it.
But small distinction there. Good question. So basically, we are at the end of the presentation. The last slide just basically shows that all 4 teams need to work together very closely, but we all have our roles at different times. And as educators, I think you have a very important role. As coaches, as athletic trainers, you all need to be working very closely together to make sure that the school component, both sides of those teams, are well managed. The quickest way for an athlete to get back to his sport is to really maximize the management on the academic side for however long that takes, so that they are completely symptom-free cognitively, so they can begin to report. So I will stop there, and if there are other questions, Jeff?
Yes, there are a couple more questions here regarding the severity of concussion and kind of that gray area of when to decide when to start taking next steps. You said, if I recall, you said that most concussions, 80%, recover or resolve within 2 to 3 weeks, 3 to 4 weeks. So symptoms that were to go beyond that, if they weren't being addressed by the medical team or the family team, when would an educator, if you will, and how would an educator go about trying to accommodate or respond to that?
Good question. So, I mean, if you think about that same scenario with any other medical condition, you would think about, well, it's pretty good odds to say that a student has some kind of a viral infection and they're going to come back in 3 to 4 weeks, or they're going to be fine in 3 to 4 weeks is a very comforting place to be. And so if you are in that 10 to 20% where that student is not getting better, the first thing we should think as educators is, what's the medical or psychological reason that's holding up the recovery for this student? And in that case, it would be a good idea for that family to go back to a doctor or see a concussion specialist and try to figure out why they are in that small percentage where they're not recovering. Schools can't necessarily demand that a family go back to a doctor, but there can be some conversations that would help parents understand that your student is a little bit on the outlier in terms of recovery, and what can we do to help them? The reality is, though, as educators, if a family doesn't go back to a doctor right then, we are still going to do what we need to support them. And so based upon your expertise as a teacher, you're going to figure out with that student what they need for longer, and you're going to work through your own MTSS or RTI process or problem-solving process to support this student and try to continually bring in the parents for what's the understanding of why, and are you going to have a medical doctor help us with this so we can get to the bottom of it. That's easier said than done, but we do that with many other conditions as well, where we think our kids need to have follow-up medical care, and we have to really work with those families to help them find that.
Sure. Okay, we have a question here from Megan Kistner, who's attending here. She says, as a parent, how do we help our school implement a better return to school plan?
Good question. So I think parents have a lot of power in trying to move forward some of these initiatives with schools. I would start with the Iowa REAP book, because it's outlined there that there is an encouragement for these students to go back to school, with the school being able to support them. So even just going in and having a conversation about what is my child's school doing? What is their protocol here? What you might find is that your school has a really great protocol for the physical side. So they have an athletic trainer who's really on top of things. They take the child out of sports, but you can then ask the next question, but what is the return to learn side? What is the protocol for that? And if there isn't something in place, could I help you get that in place? Can you look at the Iowa REAP book? Can you see that 30 to 45 minutes, students should be back, but with some of these suggested adjustments off of the symptom wheel, and see if you can get some conversation going there. There will be more and more emphasis going out to schools and educators about the return to learn components here. It's been a little bit slower to come about than the return to play, but it's beginning to come. So hang in there and maybe try to, start the conversation at the schools, and go to the Get Schooled on Concussion website and see what materials will help your school feel more comfortable and confident about taking these kids back in and supporting them.
In addition, Megan, Jeff Lauer here, the Brain Injury Alliance of Iowa with the Iowa Concussion Consortium will be mailing a hard copy of the REAP manual to all the school districts, school superintendents in Iowa. And in addition, we have the Iowa Association of School Boards and the Iowa School Administrators Organization that have committed to putting this information out in their newsletters and on their websites. Hopefully, but within 6 to 8 months, most school districts at some level will have had this visibility. The other piece here that's bringing more attention to the need to bring a REAP protocol or this kind of protocol on board is that schools are more conscious of wanting to avoid being responsible for the additional injury to student athletes from returning to play too soon. Basically, they want to avoid litigation, as they should. In Bedford, Iowa, last year, I believe it was last year, there was a $1 million legal settlement around a case of concussion management that wasn't managed well. There is a question here from Todd Johnson. The question is, for athletes who may be suspected of having a concussion, could you please speak to whether or not to administer non-prescription medication to relieve headaches or other symptoms?
Good question. Yeah, and I apologize that we did not go into as much detail about that, because that also could be its own training in terms of sideline evaluation and all, and maybe we can do that sometime. Yep. So the difficulty with that question is some of that has to do with timing and all. If you are asking as an athletic trainer, you're on the sideline, you suspect there's a concussion, in that very moment, at that time, I think you're going to have to follow your school guidelines about, your assessment and whether or not you're going to make the call that that's a concussion and transport the student, or not transport the student, but tell the parent to, here's the home care recommendations, that kind of thing, might really be more of the question versus do you give a medication at that time, because case by case, you'd have to make that decision case by case. It wouldn't be possible for me to just say that you can or can't. For the most part, the concerns that we have with ibuprofen and bleeding and those things is more of an adult issue and less of a child issue. But until this student has been determined to not have a bleed and to, yes, have a concussion by whoever that is, whatever your protocol is here, whether that's an emergency room or urgent care, I'm not sure if you want to be the one to be administering any medication right there on the spot. So if I'm understanding the question correctly, for me, it's more the bigger issue of you have to make sure you're clearing that there's not a bleed first and foremost, and then the question of these other medications would be, generally are okay in the context of concussion, but that wouldn't be the first question on a sideline.
Got it. So when in doubt, check with a licensed healthcare practitioner.
Exactly.
All right. Well, thank you, Dr. McAvoy. This hour went by very quickly. Apologies for the hiccups of technology at the beginning, but we were able to get things working. You folks can stay tuned. We will push information out about the REAP program as well as concussion management starting now for the next 12 to 24 months and beyond. A couple of things to recognize is that the science around concussion and concussion management is changing. It has changed over the last 4 or 5 years. There's new information that is emerging every month. And so this manual will be updated and our protocols will be updated on a regular basis as well. Although what we have in here in the REAP program and the REAP manual right now, fortunately, does no harm. To the best of our knowledge, there's nothing in here that will do harm, although we used to think the same thing about keeping kids in a dark room for days and days, and turned out that wasn't the best for concussion. So generally, it doesn't do any harm. If it does, we'll announce and let people know which way to go. The other component is that we do have the current REAP manual, and we will keep it updated at BIA.org. That's www.biaia.org/ICC for the Iowa Concussion Consortium. You can look for more exposure and input from the Concussion Consortium in the coming months. The Concussion Consortium's goals, in addition to reducing the adverse impacts of concussion through recognition, assessment, and management, the goal is also to reduce the occurrence of sports-related concussions through increased public and professional awareness, training, safety practices, and policies. And so hopefully you'll join us at the local level, the regional level, and state level to try to push best practices into the teams that you are part of, your communities, your families, if you're medical practitioners, your colleagues, athletic trainers, those of you in the school physical team, and also those educators who are here today. Thank you very much for all of you who've taken the time, and please feel free to email your questions if they didn't get answered today to info, I-N-F-O, info at biaia.org. Karen, any last admonitions?
No, thank you for having me, and let me know how I can help in any way in the future.
Great. Thank you all, and have a great weekend.